So next, let's talk about general and local anesthetics. Your chapter of the text here also covers some of the non-polarizing and depolarizing neuromuscular blocking agents and their effects on the patient. Let's get started. So anesthetics are drugs that reduce or eliminate pain by depressing nerve function in the central nervous system and the peripheral nervous system. Anesthesia, then, is a state of depressed CNS activity. There are two types: general anesthesia and local anesthesia. Balanced anesthesia is when there is the use of general anesthesia with an adjunct drug, such as an opioid, benzodiazepine, or maybe an anticholinergic. You have a table 11.3 in your textbook that lists some of these adjunct drugs. General anesthetics are the drugs that induce a state in which the CNS is altered to produce varying degrees of pain relief, depression of consciousness, skeletal muscle relaxation, and reflex reduction. These drugs are most commonly used for surgical procedures, and they're given under very controlled circumstances by an anesthesiologist or a certified registered nurse anesthetist. There's often a synergistic combination of drugs that are given, which allows for smaller dosing of each of the drugs and overall better control of the patient's anesthetized state. General anesthetics can be given through inhalation. These are volatile liquids or gases that are vaporized into oxygen and then inhaled, or parenteral anesthetics, and those are administered intravenously. Inhalation anesthetics are used for induction, and parenteral for induction and maintenance. So inhaled anesthetics that are used to induce anesthesia are inhaled gases that commonly is nitrous oxide. We hear that called laughing gas, and inhaled volatile liquids. These all end in ane. See that urethane, fluorethane, fluorane. Liquids are inhaled through an ionized or nebulization of that liquid. And so all of these are volatile, and thus they can be caustic and flammable. The nitrous oxide has a lower risk, and so there's some dental clinics that are approved to administer that one, but the others you're most likely to see only in a very strict surgical setting. Be aware that if you go to work in surgery, you'll need to be trained on the safety factors. The fire extinguishers in the surgical suite are typically a Class BC, due to the type of the nature of the fire in the surgical suite, because we have a volatile liquid and also oxygen, right? So oxygen feeds a fire. As we said earlier, parenteral anesthetics are used to either induce or maintain general anesthesia. They can also be used to induce amnesia, and amnesia we will want that when we have our conscious sedation, our procedural sedation as well. They can be used as an adjunct to the inhalation type anesthetics. So our parenteral anesthetics, some of them examples are etomidate, ketamine, methylhexatol, propofol, thiopental. You're going to see mostly ketamine and propofol used as your conscious sedation. We'll also call that procedural sedation. But any of them are available, and a lot of it depends on formularies. So adjunct drugs, well, adjunct is a very general term. It's used for any drug used to enhance clinical therapy when used simultaneously with another drug. So these will be things like our sedative hypnotics, our barbiturates, benzodiazepines, hydroxyzine sometimes, promethazine. You may recognize that as sometimes used in cough suppressants, opioid analgesics, fentanyl, meperidine, sulfonyl, morphine. There will also be sometimes that they'll use sedative hypnotics or anxiolytics and other medications for adjunct therapy. We'll also use the neuromuscular blocking agents or neuromuscular blocking drugs, the depolarizing ones, as well as the non-depolarizing. Our anticholinergics, atropine, scopolamine, glycopyrrolate is also used, and they are used primarily to help dry up some of the secretions, but they do have a synergistic effect. Of course, our mechanism of action is going to vary according to drug. What the Overton-Meyer theory proposes is that the effectiveness of all anesthetic potency is directly affected or directly related to the lipid-soluble solubility. So fat-soluble drugs are going to be more effective than our water-soluble anesthetics because they can more easily cross the blood-brain barrier to concentrate in the neural cells, with the overall effect being an orderly and systematic reduction of sensory and motor CNS function. So there's a progressive depression of the cerebral and spinal cord function as well. The indications for general anesthesia are during surgical procedures. We want to produce unconsciousness as well as skeletal muscle relaxation and visceral smooth muscle relaxation. The onset is quite rapid, and these medications are quickly metabolized. They can also be used in electroconvulsive therapy, or ECT, which is a treatment for depression. We'll talk about that in LVN 118. Often in ECT, balance therapy is used with the benzodiazepine added to reduce the risk of extended seizure activity. Adverse effects vary according to dosage and the drug used, and the sites primarily affected are the heart, peripheral circulation, liver, kidneys, and respiratory tract. Myocardial depression is commonly seen. So we talked briefly in 121 about malignant hypothermia. It is an adverse effect that occurs during or after general anesthesia or the use of a neuromuscular blocking drug, typically succinylcholine. There's this sudden elevation in body temperature, tachypnea, tachycardia, and muscle rigidity. Remember, you're going to see, often they'll see that jaw lock up first. It's a life-threatening emergency, and it is treated with cardiorespiratory supportive care and dantrolene. Dantrolene is a skeletal muscle relaxant, and it's actually required to be readily available when general anesthesia or succinylcholine is going to be given. Dantrolene is commonly used in spinal cord injury, stroke, cerebral palsy, or MS, but in this particular situation, it is used with supportive measures. It's never used instead of supportive measures, and it's used because it dissociates the excitation-contraction coupling. That's the heat-generating mechanism in the muscle. It does that by interfering with the release of calcium from the sarcoplasmic reticulum. So what happens is, in susceptible individuals, general anesthetics and the depolarizing neuromuscular blocking agents like succinylcholine produce a change in the cells, which results in an elevated myoplasmic calcium. This activates then a cascade that leads to the malignant hyperthermia. So this is why it's required to be readily available. It is also sometimes used as a pre-anesthesia treatment when there's a high risk of malignant hyperthermia. So moderate sedation, also called conscious sedation or procedural sedation, is a combination of an IV benzodiazepine and an opiate. Anxiety and sensitivity to the pain are reduced, and the patient can't recall the procedure. What it does is it preserves the patient's ability to maintain their own airway and to respond to verbal commands because they do not lose consciousness. So moderate sedation is used for diagnostic procedures, minor surgical procedures that don't require a deep anesthesia. Rapid recovery time and greater safety profiles are available than we would have with general anesthesia. So you'll see this for things like setting fractures, relocation of dislocated joints, sometimes plastic surgeries, and some procedures in children. Local anesthetics are also called regional anesthetics, and they're used to render a specific portion of the body insensitive to pain. They interfere with the nerve impulse transmission to a specific area of the body, and they do not cause a loss of consciousness. These can be topical, where they're applied directly to the skin or mucous membrane, so there are things like cream, solutions, ointments. If you're using an ophthalmic drop or an ophthalmic gel, make sure that it is a solution, a topical specifically for the eye. There are also powders and suppositories available. In the local, we'll also see parenteral. These can be injected intravenously or into the CNS by spinal techniques. With that spinal or intraspinal injection, the intrathecal injection is in the subarachnoid space, where the epidural is into that area between the dura mater and the vertebral wall. Infiltration with local anesthesia is when we supply small amounts that are injected into the area of the surrounding tissue. You might see this with something like a skin biopsy or maybe a suturing. Nerve blocks are when the injection is placed very close to where the nerve innervates a specific area or region. You probably recognize some of these parenteral anesthetics: lidocaine, mepivacaine, procaine, tetracaine. Notice that they all end in cane. So this is a key to learning your classes of your medications. Look at the suffix. Often they carry the same suffix. And that's simply because remember, their generic name is their chemical name, and that is their chemical structure, or at least part of their chemical structure. With these drug effects, we get paralysis. That's what we want, right? So first, the autonomic activity is lost, and then the pain or other sensory functions are lost, and finally, the motor activity is lost. As the local drug wears off, recovery occurs in the reverse order. Motor, then sensory, then autonomic activity is restored. This is important for the patient to know because they will be able to move the area before they can feel it. So for example, they need to know they'll be able to move their lip or their cheek, and they may not feel it. So although they can chew, they should not chew until the sensation is returned due to the risk of what? Biting their lip or their cheek, causing injury. So we'll often see local anesthetics used for surgical, dental, diagnostic procedures. Treatment of certain types of chronic pain, we'll see lidocaine gel or lidocaine patches. Spinal anesthesia is used to control pain during surgical procedures and also during childbirth. Local anesthetics are then given by infiltration anesthesia or nerve block anesthesia. So with the infiltration anesthesia, these are minor surgical or dental procedures. There's the injection of the anesthetic solution intradermally, subcutaneously, submucosally, or intramuscularly across the path of nerves, supplying a target area. They can be given in a circular pattern around the operative area. With the infiltration anesthesia, and sometimes we'll add epinephrine. Now, some local anesthetics used for this are combined with this because it's a vasoconstrictor. It's done to prevent systemic absorption of the anesthetic. It also helps confine the local anesthetic to the injected area and reduce blood loss during the procedure. We don't give epinephrine in any endpoints. So what that means is that we don't give it in the fingers, the toes, the ears, or the nose. So those are endpoints. When we constrict the blood flow and use a vasoconstrictor in those areas, we can have loss of that tissue. It can become necrotic very quickly. Our nerve block anesthesia is also used for surgical, dental, and diagnostic procedures and therapeutic management of pain. Here, the anesthetic drug is injected directly into or around the nerve trunk or the nerve ganglia that supplies the area to be numbed. So this is increasing in popularity with especially spinal injections or the nerve blocking injections due to our opioid crisis and the tapering of long-term opioid use. So there'll be a lot of patients that are going to pain management or pain specialist for the specific type of pain management where they're getting these spinal injections or these nerve blocks. Adverse effects are usually limited with these injections. They will result if there's an inadvertent intravascular injection or the medication, you're not going to be doing it, but the medication is given at an excessive dose or rate of injection. Maybe there's a slow metabolic breakdown because you've got a slow metabolizer. If the medication is injected into a highly vascular tissue. Another thing that can occur is a spinal headache. Now, a spinal headache occurs when there's a dural puncture and then there's a development of a shift in the fluids due to the puncture. So there's a hole, right? And it's leaking. And what happens here is that it has to close. Well, it's usually self-limiting. The headache is treated with bed rest and conventional pain medications. If those do not work, however, there is a procedure called a blood patch that will be done. This is a surgical procedure where the anesthesiologist will take autologous blood and it close the hole in the dura mater. They put a blood patch in place by taking a needle and putting it into the same place or the same space or right next to where the anesthetic was injected, and then they'll take a small amount of the patient's blood and inject it into that epidural space. So the blood clots and that seals the hole. The leak is closed. So we're going to stop there with this audio tape, and we will go to another where we will continue this slide deck with our neuromuscular blocking agents, our neuromuscular blocking drugs. See you in a few minutes.